Hello and welcome to the topic Small Cell Lung Carcinoma in the Respiratory Medicine module. By the end of this topic, you should be able to define what is small cell lung carcinoma, discuss the causes and pathophysiology of small cell lung carcinoma, outline the clinical features of small cell lung carcinoma, list out the investigations which can help with the diagnosis of this disease, and understand the principles of management of small cell lung carcinoma. Let's get started. Small cell lung carcinoma is a type of highly malignant cancer that most commonly arises within the lungs, and although it can occasionally arise in other body sites such as cervix, prostate, and gastrointestinal tract, small cell lung carcinoma has a shorter doubling time, higher growth fraction, and earlier development of metastasis. Small cell lung carcinoma arises in peribronchial locations and infiltrates the bronchial submucosa. Widespread metastases occur early in the course of the disease, with common spread to the mediastinal lymph nodes, liver, bones, adrenal glands, and the brain. Small cell lung carcinoma is primarily caused by cancer-causing chemicals, carcinogens that are found in tobacco smoke. These carcinogens cause damage to the DNA in cells which lead to cancer. However, the exact reason normal cells become cancerous is not clearly known. Most likely, multiple factors, including genetic and environmental ones, play a role in the development of small cell lung carcinoma in certain people. In small cell lung carcinoma, genetic changes can affect oncogenes or tumor suppressor genes, and these gene changes are acquired during life and they are not inherited. An altered oncogene promotes out-of-control growth. Tumor suppressor genes, which normally limit or stop the growth of cells, but here are mutated or altered, hence allowing cells to multiply or proliferate wildly, causing carcinomas. When the normal gene is present, they appear to prevent cancer from developing. So let's take a look at a few risk factors that contributes to the development of this condition. Firstly, tobacco smoke. Smoking is by far the leading risk factor for lung cancer. Second-hand smoking. If one does not smoke, breathing in the smoke of others can increase the risk of developing lung cancer. Exposure to radon is another risk factor. Radon is a naturally occurring radioactive gas that results from the breakdown of uranium in soil and rocks. Exposure to asbestos. People who work with asbestos are found in, for example, in mines, mills, textile plants, places where insulation is used, and shipyards are several times more likely to die of lung cancer. Exposure to other cancer-causing agents in the workplace. For example, other carcinogens found in some workplaces that can increase lung cancer include radioactive ores such as uranium, inhaled chemicals such as arsenic, beryllium, cadmium, silica, and vinyl, and diesel exhaust. Now let's take a look at the features of small cell lung carcinoma. So we understand that they are predominantly central and they arise from amine precursor decarboxylase cells. They produced ectopic ADH, which gives rise to the clinical picture of hyponatremia, ectopic ACTH release, which causes bilateral adrenal hyperplasia and Cushing's syndrome. However, this is not a typical presentation. And also Lambert-Eaton syndrome, where there's presence of antibodies against the voltage-gated calcium channels causing myasthenic-like syndrome. Other features include unintended weight loss, recurrent episodes of lung infections, as well as paraneoplastic syndromes. So paraneoplastic syndromes are a result of antibody generation from against malignant cells attacking normal tissue. Both non-small cell and small cell lung cancers are associated with paraneoplastic syndromes, although they are more common with the latter due to its neuroendocrine cell origin. Examples include anti-neuronal antibodies such as anti-Hu, anti-Yo, anti-Re, which are directed against the Purkinje cells of the cerebellum, leading to the cerebellar syndrome. The Lambert-Eaton myasthenic syndrome is a presynaptic disorder of autoantibody IgG directed against the presynaptic voltage-gated calcium channel, leading to impaired acetylcholine release. Clinically, patients present with proximal muscle weakness or wasting that improves with exercise. Symptomatic hyponatremia due to SIADH is treated with dimeclocycline, which induces nephrogenic diabetes insipidus, leading to excretion of excess water. Next, we would like to also carry out lab studies which look at blood chemistries, sputum cytology, thoracosynthesis in the presence of pleural effusion, as well as histologic findings. And here it will be a diagnostic sort of investigation which looks at the biopsy sample to look at the type of carcinoma that we are dealing with. As for imaging studies, radiography, a good posterior, anterior, and lateral radiographs are useful in identifying the primary tumor as well as concurrent parenchymal abnormalities. Mediastinal widening may indicate mediastinal lymph node involvement. A CT scan of all common sites of metastasis should be performed to stage the disease adequately. Evaluation via CT scan of the thorax, which include the lungs and the mediastinum, and commonly involve abdominal viscera, is the minimum requirement in standard staging workup for small cell lung carcinoma. Brain metastasis may be present in as many as 10 to 15% of patients at diagnosis and may be occult in 5% of patients. Consequently, an MRI of the brain should be ordered in asymptomatic patients as well as in those with neurological symptoms. Bone is a common site of metastasis for small cell lung carcinoma. A radionuclide bone scan should therefore be obtained to identify bone metastasis. A PET scan, or also known as positron emission tomography scanning, remains under evaluation for the staging of small cell lung carcinoma. The American College of Chest Physicians, or ACCP, does not recommend PET scanning in the routine staging, although the National Comprehensive Cancer Network guidelines recommend a combined PET plus CT scan if limited stage disease or metastasis is suspected. So it's shown that the PET CT's imaging is superior to PET scanning alone, as PET scanning is inferior to MRI or CT scan for the detection of brain metastasis. And also we have bronchoscopy as well as fine needle aspiration. So small cell lung carcinoma is usually centrally located and can be approached easily via bronchoscope. The advantage of endoscopy is direct visualization of the tumor, allowing for direct biopsy, as well as cytologic examination of bronchial washings. For tumors that cannot be diagnosed with transbronchial biopsy, a transthoracic percutaneous fine needle aspiration carried out under computed tomography guidance is a reasonable alternative. Now let's take a look at the stagings. Small cell lung carcinoma is staged by stage type and staging system. The American Cancer Society uses two types of staging, clinical and the pathological staging. Clinical staging involves physical exam, biopsy examinations, and imaging scans, where the majority of patients are staged with clinical staging, and this type of staging is usually used to describe the small cell lung carcinoma tumor extent. Next would be the pathological staging, and this is generally more accurate as it includes clinical staging and adds post-surgical findings. The staging system can be divided into the VAL-SG two-stage system or the TNM system, which we are more familiar with. Almost all solid tumors, including the lung carcinomas, are staged using the tumor node metastasis system or TNM system because it provides important prognostic information and is used to design management plans. Small cell lung carcinoma is characterized by rapid growth and early dissemination. Prompt initiation of treatment is hence very important. Patients with clinical stage 1A, which is T1 and N0, after standard staging evaluation may be considered for surgical resection, but combined treatment with chemotherapy and radiation therapy is a standard of care. Radiation therapy is often added at the second cycle of chemotherapy. For patients with a good performance status and non-bulky disease, intensive radiation therapy early in the course of treatment is indicated. However, radiation therapy can often be delayed for patients with either a poor performance status or very bulky disease. So, for approximately 30% of patients with small cell lung carcinoma who have limited stage disease at the time of diagnosis, management typically involves combination of platinum-based chemotherapy and thoracic radiation therapy given in curative intent. As for the management of relapsed small cell lung carcinoma, brain metastasis, and spinal cord compression, they can be divided into these three categories. Patients with relapsed small cell lung carcinoma have an extremely poor prognosis. Individuals whose disease does not respond to or that progresses on initial treatment, or those whose small cell lung carcinoma relapses within 6 months of completion of therapy, have little chance of responding to additional chemotherapy. In general, the administration of cisplatin and etoposide after vincristine failure produces better response rates than vincristine given after cisplatin and etoposide. Management of symptomatic brain metastasis includes high-dose corticosteroids, which involves intravenous dexamethasone 10 mg initially, followed by an intravenous or oral dose of 4 to 6 mg every 6 hourly and immediate whole brain radiation therapy. For patients with asymptomatic brain metastasis, systemic chemotherapy may be initiated, with plans for close surveillance of the central nervous system metastasis and initiation of brain radiation after completion of systemic treatment. Now let's take a look at spinal cord compression. Spinal cord compression is an oncologic emergency because patients rarely regain neurological function once it has been lost. New onset of back pain in patients known to have malignant disease should raise the suspicion of cord compression. A thorough neurologic examination and radiologic evaluation of the spine are indicated with any suspicion of spinal cord compression. Now let's take a look at the management of complications. Physicians should be aware of potential complications in patients with small cell lung carcinoma, including tumor lysis syndrome and electrolyte abnormalities. Tumor lysis can occur rapidly in patients with small cell lung carcinoma on institution of chemotherapy, especially in cases of extensive stage disease. The lab features of tumor lysis syndrome include hyperuricemia, hyperphosphatemia, hypocalcemia, and hyperkalemia. Patients should be well hydrated and preferably pre-medicated with allopurinol. The management of established tumor lysis syndrome include urine alkalinization, correction of electrolyte abnormalities, and dialysis if necessary. Small cell lung carcinoma is associated with a number of electrolyte abnormalities because of frequent production of peptide hormones. The most common abnormality is hyponatremia, which, if severe, may cause neurological symptoms and signs, including seizures, coma, and death. Prompt recognition of hyponatremia and its severity is important. Hyponatremia here results from inappropriate secretion of antidiuretic hormones or ADH, which results in the inability of the kidneys to excrete free water. So syndrome of inappropriate ADH is reported in about 5 to 10% of patients with small cell lung carcinoma. The serum sodium level is usually less than 130 milliequivalents per liter. And other causes of hyponatremia such as volume depletion, abnormal renal function must be excluded. The goals of pharmacotherapy are to induce remission, reduce morbidity, and prevent complications. Cyclophosphamide is chemically related to the nitrogen mustards. As an alkylating agent, the mechanism of action of its metabolites may involve cross-linking of DNA, which may interfere with the growth of normal and neoplastic cells. Carboplatin is a platinum alkylating agent that interferes with the function of DNA by producing interstrand DNA crosslinks. It can be used for the treatment of small cell lung carcinoma, which is an off-label indication. Cisplatin is a platinum-containing compound that exerts an anti-neoplastic effect by covalently binding to the DNA with preferential binding to N7 position of guanine and adenosine. Ifosfamide is a nitrogen mustard alkylating agent that inhibits DNA and protein synthesis. Last but not least, topoisomerase inhibitors such as irinotecan, topotecan, and doxorubicin. Doxorubicin is an anthracycline antineoplastic that causes DNA strand breakage through its effect on topoisomerase II and through direct intercalation into DNA, which causes DNA polymerase inhibition. It has a labeled indication for the treatment of small cell lung carcinoma. Doxorubicin has several black box warnings, including bone marrow suppression, myocardial toxicity, and secondary malignancy. Now let's take a look at surgical interventions. Gamma knife stereotactic radiosurgery is a salvage option for patients with brain metastasis for whom previous whole brain irradiation has failed. Historically, patients undergoing surgery for small cell lung carcinoma have a dismal prognosis. However, more recent data suggests that patients with true stage 1 small cell lung carcinoma may benefit from surgical resection. In summary, bronchial carcinoma is a malignant tumor characterized by uncontrolled and abnormal cell growth in lung tissues. Bronchial carcinoma is largely classified into small cell and non-small cell lung carcinoma, each having its own distinct features. Diagnosis begins with symptoms and identification of physical signs in high-risk population. Investigations help with establishing a diagnosis and assessing the extent of the disease to decide on the best management. Early stages of non-small cell lung carcinoma are resectable. Radiotherapy and chemotherapy can be done following surgery or for those tumors that are not resectable. Palliative therapy is provided for advanced tumors for relieving discomforting symptoms and improving quality of life. We have come to the end of this topic. Thank you.